Today we have Dr. Ross Wilson, University of Otago. Ross is a senior research fellow at the Centre for Musculoskeletal Outcomes Research in the Department of Surgical Sciences at the University of Otago. He's a health economist working mostly on the impact and management of musculoskeletal disorders, particularly osteoarthritis, and he is interested in bridging the methodologies of epidemiology and health economics to answer questions informing healthcare policy and delivery.
Yeah, so today I'm going to talk to you a little bit about a series of research projects that I've been involved in, looking at the long-term impacts of cruciate ligament injuries using data from the IDI. And I'll try to not talk too much about the clinical aspects or the policy side of things around ACL management, but particularly focus on some of the methodologies and some of the challenges that we faced in trying to do this sort of research. So very briefly, I guess, about cruciate ligament injuries. These are tears or sprains of the anterior cruciate ligament injury, or less commonly the posterior ligament, the one sitting in behind here. And they have substantial impacts on people's lives, on healthcare expenditure, potentially longer term impacts as well. They're very common. There are more than 8,000 of these injuries per year covered by ACC. And yes, I said substantial injury impacts on people's quality of life, pain, reduced physical activity, time off work. The most common means of treatment are physical rehabilitation, and in some cases surgery. One of our big research interests in our research centre here is osteoarthritis, and that's really how we originally came to this line of research around cruciate ligament injuries. There's evidence that links cruciate ligament injuries with a heightened risk of early onset osteoarthritis. But I think it's fair to say the evidence is fairly mixed on that. This was a systematic review published recently that looked at the rate of knee osteoarthritis 10 years or more after injury, and they found that across the 41 studies, the reported prevalence of osteoarthritis 10 years after injury varied between 0% and 100%. So I think it's fair to say that's somewhat inconclusive at this stage. Other long-term impacts have also been suggested. Again, there's little conclusive evidence here, but there is reason to suspect that there may well be substantial long-term impacts associated with these injuries, particularly through the what's known about reductions in physical activity, sports participation, workforce participation, and as these most often occur or very often occur in young and otherwise healthy people, these impacts as people are getting established in the workforce could potentially have substantial long-term effects. So that's what we set out to try to look at. So we used data from ACC, which is as you can imagine, a fantastic resource for doing this sort of work, looking at injuries and injury outcomes, particularly as it has universal coverage, so we capture essentially all injuries requiring healthcare within New Zealand, and being able to link that via the IDI gives us a broad range of outcomes, and the ability to really do types of research at a population level that probably can't be done anywhere else. I'll talk about a few different studies here. The first one is simply a sort of descriptive epidemiology, looking at the rate of injuries and their distribution over time and across the country. So in this work, which was conducted a few years ago now, we looked at data up until 2020, and we found essentially the incidence rate per per 100,000 population on the figure here has been more or less constant up until 2019, corresponding to around 8,000 injuries for the population in 2019. Somewhat lower in 2020, I guess, for obvious reasons. But at the same time, the cost of those injuries, so this is again per 100,000 population and inflation adjusted, we see that the cost of those has risen more or less doubled over 10 years or so, despite very little change in the incidence rate. So that reflects, or might reflect, I guess we didn't look specifically at the drivers of those costs, but that likely reflects the general rate of increase in healthcare costs across the board, as well as possibly a greater reliance on surgical interventions to manage these conditions or these injuries. There are differences across groups within the population. So looking at ethnicity, largely reflecting different rates of participation in the types of sports or other activities that that most commonly cause ligament injuries. So Pacific Island people who have the generally the highest rate of participation in a lot of the sports that that are most likely to result in cruciate ligament injury have the highest incidence rates. Asian New Zealanders have the lowest, and that's largely reflected in the cost, as we see as well. When we look at subgrouping by income, similar patterns, and again largely reflecting we expect differences in participation rates. In terms of costs, we notice that those differences are rather larger than the differences in incidence, and that reflects a couple of aspects. Firstly, that ACC earnings compensation is tied to pre-injury earnings. So we see that those with higher pre-injury incomes have greater costs associated with earnings compensation. There's also some suggestion that there may be differential access to care. So even if we look only at medications costs or medical and healthcare costs, there are higher per injury costs for those with higher incomes, which we think reflects probably differential access to care. Similar sort of pattern, but less pronounced when we split that up by NZ dep, neighbourhood deprivation. And so moving, I guess, on from the descriptive analysis, what we're particularly interested in is looking at what the effects of these injuries are on health service use and costs, and also on other outcomes, particularly income and employment workforce outcomes. To do that, we have used several of the linked data sources available through the IDI. So ACC claims, obviously we are working with, and that allows us to look at claims cost as well as any subsequent injury claims. Pharmaceutical claims data to look at medications and the cost of those. Hospital discharge records to look at hospital admissions and emergency department visits, and again the cost of those. Tax data allows us to look at income and benefit receipts, and we also look at a measure of employment, just simply looking at whether or not someone received any wage or salary income for the period, and the personal details table for socio-demographic measures. So we've had quite a journey through a few different sort of research designs and a few different research projects trying to answer these questions. And so I want to try to give you a little bit of a perspective of some of that journey for today's talk, particularly looking at some of the challenges that we've faced in trying to make causal inferences from this data, addressing some of the usual challenges around observational research. So there's obviously a lot of potential confounding when we look at the effects of injuries on outcomes. People who have an ACL or a cruciate ligament injury differ in a lot of ways from people who don't. They're more active. They are participating in the types of sports or other activities that that can result in injuries. As we saw, they tend to have higher incomes, and so we'd expect comparing outcomes of those with and without injuries. Obviously, there's going to be a lot of differences that that can't necessarily be ascribed to the injury itself. And so one of the standard ways to try to address that, of course, is to try to control for observable confounders. We're fortunate working with the IDI data that there's information in there on a lot of potential confounders. So we can look at previous injuries, we can look at other health service use or medication use, we can look at income, benefits, other socioeconomic measures, family status, demographics, all sorts of other potential confounders that that we might hope to be able to control for. And so we're going to use a matching approach here, and given all of this information that's available, we expect we should be able to do a lot better than just matching simply on age and sex and a few basic demographic measures. And so that's what we did. So the figure here assesses the balance or the quality of matching that we've been able to achieve across quite a wide set of baseline confounders. So the figures here show the standardized differences between those with and without an ACL injury. Before matching, the orange dots out here, and after matching, we're very close to balanced on all of those measurable covariates. So they include measures of health service use, costs, prior injuries, comorbidities or other health conditions, income, demographics, and so on. Likewise, looking at the squares of most of these measures, and you won't be able to see all of those, obviously, but on the third picture, but those are all of the two-way interactions between those baseline covariates. So we've tried to be as thorough as we can there in terms of establishing that we are able to match very well between the injured and uninjured groups across a broad set of baseline potential confounders. And then we look at outcomes simply by comparing the outcomes in the matched injured and uninjured samples. And so we found that compared to the matched sample without an injury, those who had an ACL, cruciate ligament injury, had a higher rate of hospitalizations, days in hospital, emergency department visits, prescriptions, public healthcare costs, and ACC costs. All of these are the cumulative outcomes over 10-year follow-up after the time of injury. When we look at some of our other outcomes, the results are perhaps less expected. So we see a small but very much inconclusive increase in incomes, a reduction in the receipt of benefits associated with injury, slightly higher rate of joint replacement surgery, which is our closest proxy that we have at this stage for osteoarthritis, a reduced rate of mortality, and a higher rate of subsequent injuries. So we found, to summarize, I guess, we found increased rate of healthcare use and cost, which is probably as we would expect. Relatively small effects over 10-year follow-up, but I think very plausible sort of magnitudes in what we would expect. But we also found signs of increased income, reduced welfare benefits, reduced mortality, and increased risk of subsequent injury. which, given what we know about the impacts of these injuries in terms of subsequent participation and time off work and so on, seem implausible, I think. A much more reasonable explanation we expect for what we're finding there is that we've failed to completely control for confounders between these two groups. In particular, we don't have any direct measures of someone's physical activity or their general health. The objective, or the hope, I guess, with the approach is that by controlling for a broad set of observable measures that are associated with these factors, we would hope to at least indirectly be able to account for them. But looking at the results, we suspect that we probably haven't, and there's still quite substantial residual confounding driving some of these results. And so we had to stop and rethink about how we might try to improve our ability to actually capture the effects of these injuries. And so we tried to think about whether we can identify a more suitable control group within the data that we have. And so what we considered next was looking at people who had other sports-related injuries, who we expect would then have similar activity profiles to the cruciate ligament injury group. And by restricting those to minor injuries, which we identified by having low healthcare costs and no entitlement costs, which capture earnings compensation, time off work, other costs funded by ACC for those claims, we should hopefully see no long-term effects of these other injuries, allowing us to identify the effect of the long-term effects, at least, of cruciate ligament injuries. So our approach is very similar. We match on the set of observable baseline confounders and achieve some very good matching across all of those. And then we compare the outcomes in those matched samples to try to estimate the effect of cruciate ligament injuries. And the results here are rather less clear-cut, even when we look at healthcare use and costs. So we can see here a very small but more or less zero effect on hospitalizations, a small but inconclusive reduction in days in hospital, reductions in emergency department visits and prescriptions, and increased healthcare costs, both the public sector and ACC funded costs, although both of those latter being quite a lot smaller than what we saw in the previous set of results. And when we turn to other outcomes, we see here quite large increases in incomes and reductions in benefits at about the same level as before, and similar results for joint replacement surgery, slightly increased, and reductions in mortality. So those were very mixed. And so we suspect here that the control group that we've identified has probably failed to capture a suitable control group for our analysis. In particular, the method that we use to identify minor injuries, we suspect may be capturing a lack of access to appropriate care rather than minor injuries that didn't need further care. So back to the drawing board once again. And so the next thing we considered was, rather than trying to match on measures at the time of injury, we compare our group of those who were injured at a given point in time with those who had the same type of injury, cruciate ligament injury, at a later date. The idea being that because they're having exactly the same event happening just slightly later, these people should be otherwise similar. And we also changed the analytical framework slightly, so we use a staggered differences approach. I'm sure some of you are familiar with differences in differences methods, but I'll briefly go through what we did for anyone who's not familiar, as well as to highlight the particular approaches that we used. So the simplest differences in differences approach simply takes two groups, those who are treated and untreated, or in our case, injured and uninjured, two time periods before and after treatment or injury, and estimate the treatment effect by the difference in the change in outcomes for the treated group between pre and post compared to the change in outcomes for the untreated. So that's very straightforward, but it obviously relies on fairly heroic assumptions about the using the change in outcomes for the untreated group as a reasonable proxy for the change in outcomes in the treated group if they hadn't been treated. So what is usually used when conducting a difference in difference analysis is panel data that has multiple time points of data before and after the treatment or the event of interest. And that allows us to look at whether these trajectories of outcomes prior to the event were comparable in the treatment and control groups, to give us some confidence that if the event or the treatment had not occurred, then they may have been continued to trend in a similar way after the time of treatment. In which case we can use the trajectory of the control group post-treatment as a proxy for the trajectory of the treatment group post-treatment to give us a point of comparison for estimating the treatment effects. A slight extension of that approach, which is what we used here, is where we have a context where we have different groups of observations, people with injuries in our case, who have the event at different points in time. And that allows us to use different sets of control groups for at different time points. So for example, to estimate the counterfactual no injury outcome for the treatment group 1 who had their injury at time 1, we can use the pre-injury outcomes for those who had an injury at time 2 up until prior to time 2. We can use the pre-injury outcomes for those who had an injury at time 3 up until prior to time 3. And similarly for those who had their injury at time 4, we can use those outcomes up until prior to time 4. And likewise for the group who had an injury at time 2 and time 3. Those who had their injury in the final period of the data only act as controls for all of the others, because after their injury there are no more suitable controls to consider. There are a couple of key identifying assumptions that allow us to interpret the results of this analysis in terms of causal effects. The first of those is no anticipation. So people can't change their outcomes in anticipation of the treatment. That's probably reasonable in this context. People can't anticipate having an injury in the future. And the other key assumption is the parallel trends assumption. So that's the same assumption that we saw for the basic difference in difference setup. The change in outcomes in the post-injury periods for the injured group would have been the same if they hadn't had the injury as the change in outcomes that we did observe for the those who hadn't yet had an injury. In order to estimate these models, we use an approach that splits up all of the potential treatment group by time specific effects. So the figure here shows the different groups of individuals who had injury at a different time point. So red for pre-injury, green for post-injury. So the first line includes those who had their injury in time at the second time period, and we look at their post-injury outcomes. Second line, those who had their injury in time 3, and so on. And so the estimation framework splits those up into a series of separate simple two time period difference in difference estimates. So for the group who are injured in the second time period, we estimate the treatment effect for them in their first post-injury period, time 2, by a simple two group difference in difference. So comparing their change in outcomes from time 1 to time 2 with the corresponding change in outcomes for those who hadn't yet had an injury by time 2. And then for the same treatment group, we move forward to the next period and get a separate estimate of the group and time-specific treatment effect for that group in time 3, again by comparing their post-injury outcome to their pre-injury outcome relative to the corresponding outcomes for those who hadn't yet had an injury by time 3. And we do that for all of the time periods, and likewise for the next group, those who had an injury in time 3, and so on. And then, so that gives us a very large set of group by time specific treatment effects. We aggregate those based on time since injury to summarize those results. So along the diagonal here, this is all of the effects from this from these estimates for the first period post-injury, for the second period post-injury, and so on. Then once we've done that, we'll also aggregate them up to the 10-year follow-up period by summing up all of these time since injury specific effects for comparison with the first set of matching results. We also do the equivalent estimates for the pre-injury periods. What we should expect to see there is that there should be, if the parallel trends and no anticipation assumptions hold, there should be no trend in or no difference in those outcomes in the pre-injury period. And so that's what we've looked at first. So here for the public healthcare costs outcome, these estimates looking in the periods prior to injury, if the parallel trends assumptions hold in the pre-injury period at least, we should see that these are around 0 and should have no clear trend in them, and that's what we see here. So there's obviously some period by period variation, but the magnitude of all of these is very small, and there's no clear trend in the middle. Looking post-injury for the same outcome, we can see that there are large healthcare costs. So these are per quarter costs here, per quarter per person. In the first, so we see large costs in the first year or so after injury, reducing somewhat, but still remaining elevated compared to the no injury controls, all the way out to a 10-year follow-up. Across various other outcomes that we've looked at, up the top we've got some health service use measures, so hospitalizations and emergency department visits, where we see an increase in the first period following injury, dropping down again but remaining elevated all the way out to 10-year follow-up. There's little evidence of increases in pharmaceutical prescriptions, although there's a fair amount of uncertainty around those, particularly as we get further out. Socioeconomic outcomes in the second row, employment, so that's simply measured by whether or not someone received wage or salary income for the period, drops away by about 2 or 3 percentage points in the year after injury, before recovering somewhat. But then as we look further out, there are still ongoing and actually increasing impacts that we see. out to 10-year follow-up. A similar picture for the amount of wages and salaries received, drop in the first year before recovering, and then persisting or even increasing a bit as we go further out. Over the first year or so, most of that income loss, or a large part of that income loss, is compensated by ACC earnings compensation payments, but that drops away to very small amounts the further out we look. In line with the result, an increase in receipt of other government benefits over time, although noting that the scale is quite small for this outcome. Joint replacements, we also see an increase persisting more or less out through most of our follow-up period here, and reductions in subsequent non-cruciate ligament injuries. When we aggregate those up to a 10-year follow-up so that we can compare with the results of the original matching analysis, we found reasonably increases increases in hospitalizations and total days spent in hospital in the same direction, but with about 3 or more times the magnitude of effect as we saw in our original matching analysis. We see an increase in emergency department visits, reasonably similar to those first estimates. Very little sign of any change in pharmaceutical prescriptions, in line with what we saw in the figure on the previous slide. And substantial increases in healthcare costs, both public sector healthcare costs and ACC-funded healthcare costs. And the public cost in particular, much larger than what we saw in the previous set of results. Turning to some of our other outcomes that we were able to look at, we're seeing quite different results now for incomes. So a fairly large reduction in incomes, averaging about $2,000 per year over the 10-year follow-up, compared to a small increase or inconclusive finding from the matching analysis, and an increase in receipt of benefit payments as well. The results for adverse events, joint replacement surgery is very similar to what we saw before, and in this analysis, a reduction in the number of cruciate ligament injuries. So we think that this new approach has addressed the issue of residual confounding that we were seeing with the matching analysis, but it does of course have its own limitations. We're not able to look at the mortality issue that we identified. That was one of the sort of key reasons for questioning those first set of results. That's because our control group, by construction, consists of people who had a cruciate ligament injury later, and so therefore, of course, they can't have died in the interim. And so our sample in this case is people who were alive throughout the full period. But looking at the results for the other outcomes, particularly subsequent injuries, we think that it looks like this new approach may have addressed those issues that we identified. Another big potential concern is selection on outcomes into the control groups. So if someone had health events, for example, hospitalizations, they're likely to reduce their activity and therefore have less chance of having a cruciate ligament injury and actually being observed in our control groups. And so the control observations that we're using, we might be concerned that those are selected for having better outcomes over that control period. And therefore the the negative impacts of ACL injury might be overstated by this approach. One counterpoint to that, I think, is that if that was the case, we'd probably also expect the control observations to have fewer non-cruciate ligament injuries, because that would be, one of those both a reason for not being observed as having a cruciate ligament injury if you're out of sports because of other injuries, and also potentially a similar outcome of other health events. So that might help give us some confidence that hopefully this potential selection bias might not be too severe. So to summarize all of those, we think the initial results that we obtained using the matching approaches probably underestimate the true impact of cruciate ligament injuries because of residual unobservable confounding. The staggered difference in differences approach seems useful in this context, or in any context where we can identify groups of people having an event at different points in time. But there are reasons to think that those estimates might overestimate the impacts of these injuries. But by bringing these sources of evidence together, we hope that we should at a minimum be able to put some bounds on the range of plausible impacts. And our view is that the difference in different estimates are probably closer to the truth than the original matching estimates. So we'll probably put more weight on those in terms of thinking about what the true effects are likely to be. Well, causal inference from observational data is challenging. There are a lot of threats to the causal interpretation of really any estimates of treatment effects or other injury effects in observational data. So we need to be careful in thinking about how we're estimating those and how we're interpreting them. But the data available in the IDI at least gives us the opportunity to try to address those in different ways. And we hope that some of our experience might be of interest to thinking about those for your own sort of research.
Yeah, thanks for that, Ross. That was very, very interesting. I really especially enjoyed your deadpan reading of the previous works, suggesting 0 to 100%. That was very good. That does really sound inconclusive. The very interesting, especially on your point there. I was just thinking the same thing of the very fact that you have the injury, so it makes you take time off and be less active. Meaning it's tricky to have those results. In terms of you then mentioned future cruciate ligament injuries. Did people, because based on some of those employment rate things, if you've got professional sports people, they then presumably can be out for quite a long time. But does it tend to have another injury later on? Was there both legs happening or future on the same side?
No, well, we don't think so. But I think the biggest impact really is that people stop doing the activities, and so they're less at risk. I don't think I don't have a definitive answer to that, but I don't think there's a big sort of subsequent increase in risk for those who do keep doing things. But that's not something that we were able to look at here.
Gotcha. Barry Taylor, really interesting way of analyzing the data, which will make us think of how this methodology would work in other areas. Thank you. Anika, thank you. Really appreciate the explanation of different approaches you explored and how you identified your discomfort with the results from them. Yes, and again, and bringing up the limitations, especially, and saying that you think you've pretty much worked around them by bringing it all together was really interesting.
Kia ora, Ross. For now, I just wanted to say thank you so much for that presentation. I found that really interesting. I think obviously having the right control group or comparison group is really important, and I don't think it's something that many of us have spent as long as you in terms of looking at the impact of different potential control groups. So thank you. That's great. I guess one question. How much do you think age at cruciate ligament might affect this? Like, have you
Yeah.
looked at stratified results, stratified by age?
Uh, we we haven't. That is one of the things we want to look at. Obviously, particularly with the difference in difference approach, where we're looking at people who are otherwise comparable but had the injuries at different times. That's
Mm.
um, associated with age very strongly, because someone having their, if we compare someone who had an injury in 2008 with someone comparable who had an injury in 2012, um, the person who had an injury in 2012 is 4 years older at the time of injury. So there's potential, confounding issues in there. Um, we we adjusted for um, a flexible spline polynomial, something or other of age in there to capture that. As to whether we've looked at specifically the effect of age at injury, not yet, I don't think. We may have started looking at that from the original matching ones, but given our concerns about the overall results there, we haven't looked at that too much.
Yeah, cool. Thank
But
you.
yeah, definitely, it's potentially an issue, particularly when people are, at an age in which they're entering the workforce or, establishing themselves. Then, having an injury and being off work at one point may well be different than if you're, 40 and working a desk job. It probably doesn't make too much difference.
Yeah, yeah. And in terms of, I guess, recovery, the
Yeah.
recovery pathway for a 18-year-old could well be quite different to like my brother who about a month ago tore his ACL. Yeah,
Yeah.
cool. Thank you.
Thanks. Thomas?
Yeah, thank you. A very interesting presentation and analysis, and I really enjoyed the clear and transparent explanations what is going on in the data. The thing that kind of surprised me a little bit is the shape of the labor market effects. So that there is this discrete and this immediate effect, and then there's a little bit of a bounce back, and then there is a even stronger kind of a trend downwards in terms of lower earnings and employment. Is there like a medical explanation or something other that you have that can explain that pattern?
Um, no, not at this stage, really. The the initial effect and then the subsequent, coming back up afterwards is what you would expect. Um, the acute injury period and then the recovery period. Beyond that, no, we don't yet have an answer. It may be that the impact of being off work at a point in time kind of has flow-on effects. Or it may be that there is simply too much difference between people as you go further apart in injury dates. So it might be sort of an artifact of the analysis method. Because to estimate the effect of injuries on outcomes at 10-year follow-up, we need to have people having an injury 10 years apart. And so that, the differences between those might be too great to put too much kind of weight on those. So at this stage, we're not sure. What we have done is restricted the sample to those who are to injuries that were closer together, so only up to 5 years apart, which means we can only look up to the 5-year outcomes. But we see the same initial increase and then some partial recovery after that. But yeah, looking beyond that is we don't yet have a good answer to that, I'm afraid.
Thank you. Could you look at the pre-trends for these kind of people who have the injuries very far apart, like 10 years, just as a kind of a check if they are different in terms of maybe the nice pre-trends that you showed are basically driven by the people who have the injuries close together and because they're more similar.
Yeah, it could be. Let me, yeah, so obviously the ones out here, which are on the left here, which are also close to zero, are only coming from the people who are 10 years apart.
Yeah, that's
so
true.
it's reassuring that they're here, but yeah, the ones closer to injury are much more heavily weighted to those near because there are more of them.
Makes sense. Yeah, thank you.
There was an ACC study looking at during this time period that looked at pre-surgical physiotherapy impacts. Was this survey data included in your research?
The short answer is no, it wasn't. I wasn't actually aware of that study, so that would be something definitely very useful to take a look at. But no, we haven't looked at that.